Pacemaker therapy has become one of the most common and reliable treatments for patients with arrhythmias that result in symptomatic bradycardia or conduction disorders. Pacemakers can be temporary or permanent, and the choice depends on the patient's condition. Temporary pacemakers are used in acute settings when pacing is required for a short time, often through a transvenous or transcutaneous approach. Permanent pacemakers are implanted when long-term pacing support is needed. Regardless of type, every pacemaker system has two major components: a pulse generator, which contains the battery and circuitry, and one or more pacing leads that carry the electrical stimulus to the heart muscle. Newer devices include leadless pacemakers that are small, self-contained capsules implanted directly into the right ventricle, offering reduced complications such as infection or lead fracture. Emergency pacing can also be provided transcutaneously using pads on the chest to stabilize a patient in severe bradycardia until a more permanent solution is available. Because pacemakers are used worldwide, a universal code system was developed to describe their function clearly. This is called the NASPE-BPEG code, named after the North American Society of Pacing and Electrophysiology and the British Pacing and Electrophysiology Group. The code consists of up to 5 letters. The first letter tells us which chamber is being paced: A for atrium, V for ventricle, and D for dual. The second letter tells us which chamber is being sensed: again, A, V, D, or O if sensing is turned off. The third letter describes how the pacemaker responds to what it senses: I for inhibited, T for triggered, D for both, and O for none. Inhibited means the pacemaker holds back if the patient's heart is beating on its own, while triggered means the pacemaker fires in response to an intrinsic beat. The fourth letter indicates whether the device has rate responsiveness, shown by an R, which means the pacemaker can adjust its rate based on activity, oxygen levels, or other physiologic signals. The fifth letter indicates multi-site pacing or anti-tachycardia functions. In practice, most clinicians use only the first 3 letters. An example is DVI. The atrium and ventricle both have pacing electrodes. The ventricle is being sensed, and the pacemaker is inhibited when the ventricle is active. On the ECG, pacemaker function is identified by a vertical line called a pacemaker spike. Capture occurs when the pacing spike is followed by the expected electrical complex, a P wave after an atrial pacing spike, or a QRS complex after a ventricular pacing spike. Because the impulse is initiated by the device and not the natural conduction system, the paced waveforms often look different from the patient's native rhythm. Pacemakers are generally programmed to work on demand, meaning they sense intrinsic cardiac activity and only fire when needed. If a pacemaker is set to pace but not sense, it's called fixed or asynchronous pacing, written as AOO or VOO. This type of pacing ignores intrinsic activity and may signal battery issues if seen unintentionally. The pacing mode chosen has a big impact on hemodynamics. VVI pacing, which paces and senses the ventricle and inhibits itself when a ventricular beat occurs, can lead to loss of AV synchrony and loss of the atrial kick. This may lower cardiac output and cause venous congestion, producing a group of symptoms known as pacemaker syndrome: chest discomfort, shortness of breath, fatigue, activity intolerance, and orthostatic hypotension. Atrial pacing or dual chamber pacing is often better because it preserves synchrony between atria and ventricles, reducing the risk of atrial fibrillation and heart failure. AAI pacing is recommended for patients with sinus node dysfunction and an intact AV node, while DDD pacing is commonly used for AV conduction disturbances. For patients with heart failure, synchronized biventricular pacing, also known as cardiac resynchronization therapy or CRT, can improve mortality, reduce symptoms, and enhance quality of life by pacing both ventricles in sync. CRT devices often combine pacemaker and defibrillator functions. Like any medical intervention, pacemaker therapy comes with potential complications. Early on, the most common issue is lead dislodgement, which is minimized by restricting activity and immobilizing the involved extremity for temporary systems, or limiting arm movement after permanent placement. Other risks include local infection, pneumothorax or hemothorax during lead placement, bleeding or hematoma at the insertion site, ventricular ectopy from irritation of the myocardium, phrenic nerve stimulation causing hiccups, or more rarely, cardiac perforation that can lead to tamponade. Twiddler syndrome, where a patient manipulates the device and causes lead problems, is another concern. Pacemaker syndrome itself can also be considered a complication when AV synchrony is lost. Pacemaker malfunction is diagnosed by analyzing the ECG. Problems include loss of capture, undersensing, oversensing, and complete loss of pacing. Each has its own causes, such as lid dislodgement, battery depletion, or interference, and requires adjustments ranging from reprogramming the device to replacing components. Electromagnetic interference is another concern, though most household devices are safe. Patients should avoid close, prolonged contact with magnets, keep cell phones at least 6 to 12 inches away from the generator, and be cautious around high-intensity electromagnetic sources like MRI machines or power substations. They should also avoid welding and gasoline-powered chainsaws unless strict precautions are followed. Security systems and anti-theft devices can trigger alarms, but generally don't harm the pacemaker. Patients are simply advised to walk through quickly. Importantly, patients should carry medical identification to alert others about their pacemaker. Ongoing surveillance of pacemaker function is essential. Today, most devices include remote monitoring systems, which have replaced many routine in-person visits and are linked to better survival. There are several types: trans-telephonic systems using a landline phone, inductive systems using a wand with either landline or cellular transmission, and wandless systems that communicate by radio frequency. Remote monitoring provides the cardiologist with ECG data, pacing rates, generator settings, battery life, sensing function, lead integrity, and the number of pacing events. This allows early identification of problems, reassurance for patients, and timely interventions, even if the patient lives far from a cardiology clinic. Most systems are set up to provide maintenance checks on at least an annual basis, though follow-up frequency is tailored to the patient and device. In summary, pacemaker therapy is a life-saving intervention that has advanced dramatically, from temporary transcutaneous devices to leadless permanent pacemakers with remote monitoring capability. Nurses play a key role not only in identifying appropriate ECG patterns and recognizing complications, but also in patient education, teaching safety precautions, activity restrictions, and the importance of follow-up. With this knowledge, patients can feel reassured and confident that their device is working with them to maintain a stable and effective rhythm.